Our panel discussion, we are going to start now. Moderator for the panel discussion is Dr. Amita Maheshwari. Panelists are Dr. Abraham. He's already been introduced. He's Professor and Head Obs Gynae and Head of Gynecologic Oncology Unit in CMC Vellore. Dr. Manas Biswas, he's Professor and Consultant Gynecologic Oncology, Department of Obstetrics and Gynecology, Command Hospital, Air Force, Bangalore. Dr. Krishnanshu Tiwari, Professor and Director Research, Principal Investigator for Energy Oncology and GOG Legacy in UC Irvine. And Dr. Indukala, she's a Senior Gynecologist, ex-Professor and Head of the Department of Obs and Gynae from Bangalore Medical College, Bangalore. And Dr. Kiran Kattimani, he's a Senior Medical Oncologist from Hubli. And Dr. Vadhiraj, he's a Senior Consultant Radiation Oncologist from Manipal Hospital. Now I would like to call Dr. Amita Maheshwari to start the panel discussion, please.
The aim of this panel discussion is at the end to give you some clear pictures, because theory we have already heard since morning. What we want now, practice guidelines once you go back, what to do in practice. So let me come straight to the problem. So she's a 57-year-old postmenopausal lady, diabetic, hypertensive, hypothyroid, obese with the BMI of 35, the usual, with one episode of postmenopausal bleeding per vagina. Now, she had a pap smear 6 months back, which was normal. A clinical examination is normal. So my question is to Dr. Indukala, this lady comes to you, what will you do next?
In my unit, what we would like to do is, of course, a proper history and then a good clinical examination to rule out other causes. The
Right.
first investigation we would ask for is a transvaginal
Okay,
sonography.
so that's what we also did a transvaginal sonography which showed grossly thickened endometrium. So do you think this lady, with so much high risk, is she a candidate for hysterectomy with thickened endometrium?
Yeah.
How many of us will think that she deserves a hysterectomy straight away?
No, she needs further investigation.
Okay, so yes, ma'am.
Further investigation she needs. And of course, in our hospital, we don't go for any other type of investigation other than the hysteroscopic guided endometrial biopsy.
So the point here is that clinical profile and imaging alone not sufficient to warrant a hysterectomy. What you need is endometrial biopsy before, some of you may be scared of losing the patient if you send her for biopsy, but that's absolutely must. The question is, what is the optimum method of taking biopsy? Dr. Indukala said that at her center she takes hysteroscopy biopsy, which will be under anesthesia in the theater. But is there any different opinion from Dr. Tiwari, Dr. Biswas, Dr. Abraham? What is your practice?
Our practice is we should see the patient profile, and we would do an office endometrial biopsy.
Right.
Sensitivity is 95%.
Right, absolutely. So if you have people biopsy, I think that's fair enough when sensitivity is 95%. Dr. Tiwari, what do you do at your center?
Yeah, if the patient came to me, either I'd do the biopsy right away because she's 57 bleeding, or I would order the ultrasound, but either way I'm going to schedule her for robotic hysterectomy. She's 57. Even if the biopsy is negative, she doesn't need her uterus. She probably has hyperplasia, she's obese.
No, I mean, there may be another issue if this is just a polyp on hysteroscopy. I don't know whether she really deserves a hysterectomy, but yes, what the message is, endometrial biopsy is required. Depending upon your, protocol, institutional protocol, it can be a Pipal biopsy, which has very good sensitivity, more than 95%. If not, the standard is a formal DNC with hysteroscopy. There's some concern about hysteroscopy if you strongly suspect cancer. What is the current consensus? Is there a risk of spread of malignant cells in the peritoneal cavity? Do you really do when you, very, very strongly suspect malignancy?
Yeah, I don't do hysteroscopy at all. I don't think there's anything wrong with it, but if you have a postmenopausal patient that's having bleeding, I don't recommend it. I think hysteroscopy is better for younger patients that are having abnormal bleeding that may have a polyp or something like that, but if you, because hysteroscopy can spread tumor cells, through the fallopian tubes.
Manas, I think you seem to differ, right?
Yeah, the current evidence in literature states that by doing a hysteroscopy, it doesn't spread the cancer. So you can go ahead and do a hysteroscopy. If you are, if there is a very frank suspicion of cancer, we would do an office endometrial biopsy. Why go in for a hysteroscopy?
So if Pipal biopsy is negative, then maybe I'll subject this patient to. But in if Pipal biopsy is positive, then there is no need to subject her to DNC and hysteroscopy. Okay, so Dr. Abraham.
Yeah, I would do a Pipal straight away as soon as she gets on the table, irrespective of the ultrasound findings. I would do the ultrasound later, but all patients with postmenopausal bleeding, first episode also, I would do a biopsy. If it comes back negative, I would then do a hysteroscopy. Outpatient.
Okay, so I think what Dr. Abraham is saying little different. He said once you're examining the patient straight away, like we collect pap smear, he will do endometrial aspiration. But most centers actually would do a sonography first and then prefer doing either Pipal or whichever kind of biopsy.
Okay, can I ask a quick question?
Yeah.
What's the point, assuming this lady has insurance and they'll cover surgery, what's the point in leaving this lady's uterus inside? She's 57, she's obese, she's at risk for endometrial cancer if she doesn't have it now. Why just,
Dr. Tiwari,
why
you
do all
should
this
be
stuff?
practicing in India. Why did you
You
go
should
to...
be practicing in India.
So most our gynecologists believe in what you are saying. Anyways, I think...
That doesn't happen, that doesn't happen. Now,
No, but I'm not sure if you are justified doing a hysterectomy medico-legally if it is a polyp.
But if we do a DNC and if it is endometrial cancer, then you might consider pelvic lymphadenectomy, and the treatment is different.
Okay, so but Dr. Tiwari...
in their setup, they would do a frozen. That's why he said that.
No, but I would
But
defer...
that is not a, that is not a evidence-based guideline. So I think
No, I would
lot of
defer.
postgraduate
I would defer from you, Dr. Tiwari. One, because not all OBs, this kind of patients are going to develop endometrial cancer. That message should not go. That all high-risk patients should undergo prophylactic hysterectomy. And suppose if this is a polyp, then just polypectomy is sufficient. So I think we are a little diverting from the issue. Anyways, Dr. Indukal, I come back to you. The biopsy, whichever we did, came out as moderately differentiated endometrioid adenocarcinoma. So, yes, yes. So the thing is, what will you do? Are you happy managing this patient, or what will you do? Now,
I wouldn't do that, and we always refer the case to the regional cancer center for further management.
okay. So, any one of you differ here, audience? Some gynecologists think that because ultrasound didn't show any myometrial infiltration, it was just a thickened endometrium and it turned out to be cancer. How many of you think that gynecologists should manage this patient and not to refer this to an oncologist, especially in the light of recent MRC trial which suggests that lymphadenectomy has no role in early endometrial cancer? Anyone? Sorry? Yeah. Yeah. Right. Right. So what message actually I want, even early cases, not doing lymphadenectomy should be an act of commission, not an act of omission. That means you assess lymph nodes, you know that lymphadenectomy is not required. It should not be just because you can't do lymphadenectomy, you are not doing. And remember that even in MRC trial, 9% of patients in the observation arm underwent lymphadenectomy, and lymph node assessment was done in all cases. So just doing simple hysterectomy, not looking in the retroperitoneum was not part of the trial. So please don't extrapolate from MRC trial as an excuse for doing simple TAH, BSO for so-called early endometrial cancer cases. Okay, coming back, what is the appropriate pre-operative imaging at your center? Maybe Dr. Abraham, Manas, and Dr. Tiwari. Dr. Tiwari, I think he'll say nothing is required because he's happy with straight away posting, but let's see. Manas, what will you do? What imaging?
We have done an ultrasound, we'd go ahead and operate.
Okay, Abraham?
We maybe individualize some cases and get an MRI done, but
Okay.
ultrasound.
Okay, Abraham, what is your?
Like I said in the morning, I would do imaging only in the young patients where I'm not operating. When I'm going to operate, I'm not too keen. Though in my unit, now we have started doing ultrasound because some of my other colleagues felt that at least an ultrasound examination would
Right, so I think there is no consensus and there are no guidelines which imaging. Most people will say a good quality sonography is good enough, and what we are looking actually not something in the primary uterus or in the retroperitoneum, it is just for any incidental finding which you don't want to miss, something in the liver or gallbladder, things like that. Otherwise, some people do CT scan. MR has very, very specific indication and should not be done in all cases. But the message, what I want to give, that PET CT scan, which is a new fad in our country, should not be done as part of pre-operative workup of endometrial cancer cases. It has very, very specific indications. So please don't do PET CT for all cases. Yes. Some imaging, yes, we all do actually, let's be honest. Our policy generally either a sonography or a CT scan at Tata Memorial Hospital. But one should know that yield or sensitivity of both CT and MRI in picking up retroperitoneal lymph node is poor, ranging from 50 to 60%. So don't rely on these imaging findings for or your intraoperative decision making. Okay, so we come to your favorite thing, Dr. Tiwari. This patient, we have finally decided to subject her to surgery. What will you do?
Robotic hysterectomy, bilateral salping oophorectomy, and bilateral pelvic lymph node dissection, and possibly periortic nodes.
So how do you, Manas, before we decide about the extent, let's see whether it will be open or minimal access. And what is the current evidence? Manas and Dr. Abraham?
Current evidence states that you can go ahead with minimal access surgery, be it laparoscopy or robotic surgery, and the outcomes are similar. The advantage being, short-term advantage being blood loss, hospitalization, long-term all same.
Right.
Whether it's open or whether it's minimal access.
Right. Abraham, you want to add something? And what is your practice at your center?
Well, I would, like Mana said, that there's no question that minimally invasive would be really the best way to do it for really obese patients. And like Dr. Somaswika said in the morning, that if you have a robo, that would be the way. I would love to have a robo. But since we don't have it, and I'm not a good laparoscopic surgeon, I'm still doing open surgery. And we really don't like that, because if they have such a big pannus, then sometimes we do a long transverse incision.
Yeah.
Most of the time we do a midline incision.
Okay. So, yeah, the current evidence suggests that laparoscopy is same in terms of oncological outcome as open surgery. Minimal access has certain short-term advantages in terms of quality of life, but at 6 months or beyond, there is no difference between between minimal access and open surgery. So if you have expertise and facilities available, go for minimal access, but if not, then continue with open surgeries. Okay, so what are the advantages? Of course, we have already discussed advantages of laparoscopy over robotic. Anything you want to highlight, Dr. Tiwari? You said your choice is very clear, you will go for robotic now.
Yeah, I'd do a robotic operation. If I'm in a hospital that doesn't have a robot, I'll take her to a hospital that does. If there's no hospital with a robot, I'll do it with the laparoscope. And if she's got deep myometrial invasion, I'll do her upper aortic nodes.
Okay, so any particular, what precautions will you take while doing hysterectomy for endometrial cancer case by minimal access surgery? Manas, generally laparoscopists, they put myoma screw and then tend to manipulate. So what precautions one should take while doing hysterectomy through minimal access approach in such cases?
Hysterectomy, as you say, in minimal access?
Yes.
I mean, just now we saw a robotic surgery and they used a V-care, which first and foremost, there's no manipulation inside the uterus, and we would avoid, in case we are doing a laparoscopic hysterectomy, would avoid using a manipulator which is inserted inside the uterus. I would take care of that. I wanted to ask a question to Dr. Tiwari. Dr. Tiwari, in your center, would you do a vaginal hysterectomy with BSO and then plan whether you want to do a minimal access?
No.
There are centers which are doing in the morbid, obese patient. They would go ahead and do a vaginal hysterectomy with BSO and then send it for frozen, because if it fulfills the Mayo criteria, and they would stop the surgery, and that would be the best outcomes as regards morbidity?
Yeah, it's
Well, it's not the standard of care,
Right.
but do you do it? I mean,
before we had laparoscopy in my fellowship, one of my professors did vaginal hysterectomies on morbidly obese patients. I'm a co-author on the publication, but I don't like to be uncomfortable. Why do I want to do a vaginal hysterectomy? You know, you're operating in a little hole. It's sometimes hard to get that nexa. There's no opportunity for staging unless you want to do laparoscopy later. But if the patient can tolerate laparoscopy for nodes, they can tolerate a minimally invasive hysterectomy.
Right.
I don't like to struggle.
Right. So vaginal hysterectomy, I think, has some role in, especially in morbid, patients who can't stand abdominal procedure can be. But the main drawback I feel, even if you are doing TAH, BSO, removal of ovaries is rather difficult, especially in obese patients. Unless, sometimes ovaries in postmenopausal women, they are very lateral and almost gone to the lateral pelvic wall. So you have to really struggle to get those ovaries out vaginally.
Just one, I think vaginal hysterectomy is the least invasive. So I think we have to accept that vaginal hysterectomy is the least invasive, even compared to robotic. But there are problems. You have to remove the ovaries. No point leaving the ovaries behind. Second thing, you can't bisect. We do get cases where the uterus is bisected and removed. That should never be done.
Right. So in exceptional case, when patient is, not fit to undergo abdominal surgery, one may consider vaginal, but that's, at least in our country, is not the recommendation. Okay. Now coming to the favorite question, what should be the extent and how do you decide the extent of surgery? So this patient, after hysterectomy, we opened the specimen, found around 2.5 centimeter tumor at the fundus with superficial myometrial infiltration. She is grade 2. Tumor is at the fundus. So what will you do? Maybe all three surgeons give their opinion. What do they do in their practice? Start with Dr. Abraham.
Yeah, if it's on size criteria, we need to do some nodes.
Mm-hmm.
So if it is grade 1, grade 2, I would do pelvic lymph nodes.
Okay.
If it is grade 3, I would do
No,
parotid.
this case, so she's grade 2. This is the size, this is the location, superficial invasion on frozen section examination. What will you do?
I would do pelvic lymph nodes, and then if there's any obvious nodes in enlargement, or I would do parotid as well. And we haven't been really doing frozen, but I think the ideal would be to do frozen on those pelvic nodes and then decide.
Manas?
With this grade 1, grade 2, I would do dissection up to the infra-IMA. And if in case I have frozen, I would do frozen. And if no pelvic nodes are positive, I'll go renal.
Dr. Tiwari?
There's really no right answer, and so the best thing to do is to be consistent in your practice. Both of those things were great. I thought what Dr. Sumshaker's doing today, sending all the pelvic lymph nodes for frozen section, is also a good idea. What I do, someone who has a grade 1 cancer, I don't even do the nodes until I get the frozen section. If it's less than 50%, I don't do them. I have not had a patient relapse as far as I know. I haven't been prospectively tracking it, but I haven't. If I have a grade 2 cancer, regardless of whether there's myo-invasion or not, I do the pelvics and lower aortic nodes, and if there's more than 50% invasion, I do the upper aortic nodes. No evidence to suggest that's the right thing to do, but that's what I do, and if it's a grade 3 cancer, I do full pelvics and full aortic nodes. But there's just no data, and it's just...
so I have a question, what is the point doing inferior epigastric IMA nodes, So what is the point, if you want to do para-aortic, we know the drainage is right up there. What is the point in studies? Whatever, Mayo Clinic data has suggested whenever para-aortics are positive, they are positive between IMA and renal. So if you want to do, I think it should be up. Otherwise, just do bilateral pelvic.
No, that was Mayo's criteria and study, but there are newer evidences. Recently, there's a good literature by SGO guidelines, which they are promoting this exactly same thing what Dr. Tiwari and I said.
But based on what evidence?
Things are moving
because
ahead.
I think the best evidence we have, at least
they go by lower infra-IMA and supra-IMA.
Infra-IMA actually is hardly ever positive, so it is either bilateral pelvic, and if you want to do para-aortic, whenever indicated, it should be right up to the renal. That's what literature suggests.
But the literature, so all that literature is retrospective and it's poor literature. So what we want to do is the whole point of coming, all the way over here and talking to all of you and including some of the other things I'm going to talk about at this meeting is to talk about good evidence-based medicine. And and endometrial cancer is the one disease where we've got nothing
Okay.
good. And so it's really going to be about being consistent in your practice with what you do.
Okay, so there are some controversial issues and there are no consensus. It's, what Dr. Tiwari said, you have to be consistent in your practice so that at the end you are able to generate your own data and you learn from your own patients. Anyway, this particular case, we get the final histology saying moderately differentiated endometrioid type 1 type of adenocarcinoma with superficial myometrial invasion, 2.5 centimeter tumor. Dr. Adiraj, any indication for adjuvant treatment? Do you think she deserves anything?
As per the evidence, no.
Okay,
Patient
no,
doesn't
but
require any
we are not talking about non-evidence things. What do you do otherwise outside evidence? No.
Stage 1A grade 2 sometimes, because if we see NCCN, they say plus or minus vaginal brachytherapy. So if one of 20 patients are going to fail, that is less than 5%. In these kind of cases, maybe 3%.
Okay, so you actually gave very nice talk, but for the purpose of this panel, if you can just tell us when will you give brachy, when will you give EBRT, and when will you consider a whole abdominal radiation in patients of endometrial cancer? So brachytherapy indications?
Brachytherapy is stage 1A,
Okay.
grade 3, more than 60 years.
Okay.
So if high risk features, stage 1A, grade 3, we will do that. Stage 1B, grade 1.
Do you really consider age always?
That's
We
what is
don't actually. Yeah.
So that's
Okay.
what they recommend.
Okay.
But there are, for a stage, this particular case, some of them do practice because they don't want to see even that 1 in 20 failing.
Right.
So, but the
So what
incidence
is
so
important at the end, you discuss with the patient and explain everything to the patient that, this is the risk of relapse, and very important to tell patient to come for follow-up, the importance of follow-up. If you know this patient is never going to see you again, I think it's better to at least document and do best whatever, because that's a real problem in our country. Patients, they just come once and then, you never see them. Okay, and then when they come back, it will be with large bulky disease. Okay.
Right. So the stage 1B, grade 1 and 2, though they fall in intermediate risk, I still recommend vaginal brachytherapy.
Okay.
And the high intermediate risk group above 60 years with LVSI and stage 1A, grade 3 and plus the more than 60 stage 1B, grade 1 and 2, I recommend vaginal brachytherapy.
Okay.
If the patient has stage 1B, grade 3, I give pelvic irradiation plus vaginal brachytherapy. Probably the medical oncologist will consider chemotherapy also.
So the basic thing is one has to actually kind of weigh between treatment related morbidity versus survival, and after discussion with the patient
just a
and
second.
evidence, yeah.
So I want to mention this. So lymph nodes, there's no good studies. But for adjuvant therapy, we have good evidence-based medicine. GOG 99, fully staged patients like this one, radiotherapy or no radiotherapy, no difference in survival. Subset analysis, age less than 50 with all three factors, lymphovascular space invasion, deep myometrial invasion, grade 2 to 3 lesion. Adjuvant radiotherapy may help local failure. Age 50 to 70 with 2 of those 3 factors, give them adjuvant radiotherapy. Grade age over 70, 1 of those high risk intermediate factors, radiotherapy may help improve local control. For patients with advanced disease, GOG 122, whole abdominal radiation versus chemotherapy.
We'll come to that, right.
Chemotherapy improved overall survival, progression-free survival, and response rate. So
The only thing is GOG 99, although there was no difference in overall survival, but disease-free survival was better in the arm which received radiation. So as I said, if follow-up is going to be a problem, you have to really decide what you want to do, because their recurrences were picked up early and they were treated, and that's why there was no difference in the overall survival. But if you are not going to,
This is one point. I mean, if you have done a systematic lymphadenectomy, cleared all the nodes there, and they are all negative, then what's the point of giving pelvic radiation?
No, we are talking about brachytherapy in intermediate risk patient, whether to give brachy or not.
Brachy.
Okay, let's quickly move on to
just
little
1 second.
advanced, yeah.
He was mentioning if systematic lymphadenectomy is done, whether we need to give pelvic irradiation. In case of stage 1B, grade 3, or if LVSI is present, still there is a pelvic chance of
yes,
recurrence.
absolutely. There we have to give. So this is rather advanced patient who underwent a proper surgery, poorly differentiated tumor with positive lymph nodes, stage 3C2. What is the appropriate adjuvant treatment for this patient? What will you do? Yeah, sir.
Stage 3C2.
Yes.
Chances of the patient having distant metastasis is extremely high. So definitely after surgery, we'll consider adjuvant chemotherapy. As of today, we have good data for paclitaxel and platinum drugs which include carboplatin, paclitaxel and carboplatin. 3 cycles, and because it is stage 3C, I would definitely discuss with our radiation colleague to add radiation. That could be done, that could be sandwiched with the chemotherapy, 3 cycles of chemo, sandwiched with radiation therapy, and then complete another 3 more cycles of chemotherapy.
Right.
That is one option. Another option is sometimes we do see after surgery, the patient would be referred directly to a radiation oncologist because the role of radiation is definitely more than compared to the role of chemotherapy.
No, in this situation, no.
Yeah, in this situation, but in general,
Right.
what's the...
There's no role for radiotherapy.
Yeah, but stage 3C, sir, even the local radiation, local recurrences also will be pretty high.
No, so I did an ancillary data study on GOG 122.
Mike, please.
Chemo versus radiation. And even with one single positive node, chemotherapy alone was better. So for advanced disease, I don't think there's any, the sandwich therapy is a phase 2 study. There's no confirmatory phase 3 randomized studies, just give them chemotherapy.
So maybe one other alternative will be to give
Other
6 courses of paclicarbo and brachytherapy, vaginal brachy. That's
Actually, more and more evidence coming in towards, since radiotherapy doesn't improve overall survival, the only improvement is loco-regional. So more treatments are being done only with brachy and straight away to chemo
right.
in combination,
so
not
combination
with
of
EBRT.
chemo and brachytherapy.
Yeah,
So-
definitely. That's an option.
Yeah, that's an option.
Chemo only, 6 cycles of chemo.
Someone with a positive node is not going to recur in the vagina.
She can recur there also, but yes, she will not die of vaginal recurrence.
Show me one case.
No, but I think brachytherapy is quite safe with recent fancy techniques, so toxicity is not that much. Yes, sir.
So GOG 249, GOG 249.
Yes, sir.
Evidence is great, lovely, I understand. Now, everybody says it may increase local recurrence but will not take care of survival, provided this lady is a follow-up regular.
Exactly.
You see, when you have a local recurrence and don't follow it up, this will definitely give rise to all kinds of problems. So our textbook is on one side, our practical, see, our mind should be where it is and our heart should be where it is.
Right. So yes, individualization of treatment.
So if you do not take care of the local pelvic disease, you may be over-treatment in most cases, but then you are making sure that you don't have distant recurrences.
Right. So anyone for extended field radiation in this situation, sir, after 3 courses of chemotherapy, would you, doctor, would you think of giving EBR, extended field radiation, inverted Y, to sterilize the remaining after chemo?
If para-aortic lymph node is positive, we consider extended field irradiation.
You do.
If it is positive, then
You do consider after chemotherapy, and your patients tolerate it
it
well?
would be toxic. It would be quite toxic because
And,
the patient is.
and
heavily
what do
treated
you
with
use like
chemotherapy.
there? You have to have IGRT or
We use IMRT.
IMRT.
there.
So I think
There is a mixed school of thought here. When chemo is given, you don't have to do an adequate paramedic or abdominal assessment. It's not required because the gut toxicity cancels the benefits you have. Alright? Both in CS cervix and in endometrium. Pelvis, yes. Paramedic,
right. So one has to be very, very careful giving extended field radiation because toxicity can be very severe and it's very difficult to manage. So definitely, and I think POTEC 3 is looking at this issue specifically. Chemo definitely has to be given. Radiation, one has to think whether it may be vault brachy. Anyway, moving on to the next case. This actually we have already discussed somewhat, not so rare in our scenario. Anyway, the optimum time is second week on, you can start safely, patient is...
Usually after 2 or 3 weeks of the surgery, that's
Right.
what we practice.
So, I think this is because an important issue. A patient who underwent hysterectomy and bilateral self-oophorectomy for DUB and found to have endometrioid adenocarcinoma, how will you manage this patient post-operatively? So this, of course, we really discussed a little bit, but maybe if one of you can summarize what is your approach, Dr. Abraham, what will you do?
I mean, it's always a big problem. I mean, first of all, you have to speak to the surgeon, get the specimen, the slides, the blocks, the remaining specimen, get a path review, and then, have an estimate of how big the tumor was, etc. And
yes,
then
all these are very important issues, what he casually mentioned, but these are very important while deciding the further management.
Whether there's LVSI and so on. And if any of these high-risk factors are there, then I think I would go ahead and do a completion staging. But if it was a small tumor, superficial invasion and grade 1, no LVSI and all that, I would leave her alone. And then, of course, there's an option of radiation for her in case she refuses a second surgery, but that's
okay, so if, let me tell you our policy, what we do, we review all these characteristics, what Dr. Ibrahim said, and then we do a post-operative imaging just to be a little more sure. If imaging is normal and if she otherwise falls in low risk category, we keep these patients under close surveillance. But if she is high risk, for nodal metastasis, we offer them either to undergo a staging procedure if patient refuses, which happens actually many times. Many of our patients are not keen to undergo one more surgery. Then we offer them radiation therapy.
How sensitive is post-operative?
Yeah, it's not very sensitive. It's even worse than pre-operative. But if you find some, definitely we enlarge node, and then of course. It does, and it gives some confidence.
And even here, the PET scan, because of the immediate post-surgery,
PET
you
scan,
can't do
no.
it. So,
no PET
there's
scan.
no PET scan. I mean, if at all, a CT scan or MRI might.
Exactly.
Inflammation and, I just wanted to bring that up, that no PET scan.
Right, no PET scan.
I think you should again, it's about being consistent in your practice, and you should do what you would do if you were the person who was doing that and you got that at your frozen section. So I don't order imaging pre-operatively, so I wouldn't order it now. But if I have a grade 2 lesion, superficial invasion, I'll do her nodes. And so that's what I'd counsel the patient to do.
The question is, this patient already had surgery outside. Would you subject her to lymphadenectomy again? Absolutely. Okay, so let's move to type 2 histology. An old lady, endometrial biopsy suggests uterine papillary serous carcinoma. Now quickly, how will you image her pre-operatively or no imaging here also, Dr. Tiwari, and how will you manage her surgically?
So, retrospective data, again, does say that half of these patients present with upper abdominal disease. So this patient I would image because it'll dictate the route of surgery that I'm going to do. Because nothing wastes more time than putting the laparoscope in and then telling the team, oh, she's got metastatic disease, we got to open her up, and the robot needs to be broken down and all that stuff. So I would image this lady.
Manas, how will you manage? What will you do?
Imaging just the way Dr. Tiwari said we need, because there could be an extra uterine disease.
So what imaging, would it be CT scan or what is the preference?
CT scan?
Yeah, Dr. Tiwari?
Tell us.
Yeah. Oh, contrast CT scan?
CECT.
CECT, maybe a good idea to look at chest also if you have not done an X-ray. Yeah.
And then for surgery, basically if there is an extra uterine disease, it would be a debulking surgery. And otherwise, one should also go ahead with the omentectomy apart from the THBSO.
Do you think, this kind of
pelvic and para-aortic.
type 2 histology is little advanced disease, minimal access. Are there any drawbacks? Is there a higher risk of relapse after minimal access? Is there data to suggest?
If it's advanced disease?
Yes, if it's advanced disease, if there are nodes, enlarged nodes. No, it's a deep infiltration, bulky uterus around 12-week size with enlarged nodes. So would you?
If you can get it out, if you can get it all out, it's fine, and you're going to give that patient chemotherapy anyway. The problem is if you can't get all the disease out.
So is there any evidence to suggest that there is increased risk of port site metastasis and intraperitoneal dissemination in advanced, especially type 2 histologies if you manage by minimal access surgery? Tumor biology, is there,
I think if there's ascites present,
Yes,
it'll increase your risk. And so if there's ascites, probably minimally invasive is not the way to go. But if there's not malignant ascites, no carcinomatosis, if you can get it out minimally invasive, I think it's fine because you're going to give them chemotherapy anyway.
Okay, so we did surgery, surgical staging. Actually, UPSC, uterine papillary serous carcinomas are treated like epithelial ovarian cancer. Surgery there is hysterectomy, salpingo-oophorectomy, pelvic and para-aortic lymphadenectomy, and omentectomy. And this patient, we did everything. The finally turned out to be node positive, but omentum was negative. So what adjuvant treatment and how will you plan adjuvant? Will it be chemo, radiation?
Definitely chemotherapy is indicated here. There is absolutely no.
But does it work? It is indicated, but does it work in UPSC?
Yeah, these are going to be aggressive histologies, and the chance of recurrence is also on the higher side. But as of today, post surgery, what best we can do is offer chemotherapy, 6 cycles, the complete dose.
What chemo you give?
The standard one which is being practiced across the globe is paclitaxel carboplatin again.
Right.
There have been studies to see whether adding a third drug, does it increase the response rates and increase the overall survival, but those studies have been negative.
Yeah, only
and,
toxicity increases,
only
right.
Toxicity increases. And the standard practice is to go with paclicarbo, 6 cycles.
So, sir, any role of radiation? Would you consider radiation?
No, it falls under high risk.
He has given 6 courses of paclicarbo and now patient comes to you.
I think it's already discussed. Since the patient falls under high risk, so it's mainly chemotherapy.
Mainly,
and,
but
no radiation.
No radiation?
Because either way they are going to behave badly.
Okay, okay.
In spite of chemo.
Okay, so
And
is
just to add-
this the practice, Dr. Tiwari?
Yes. So we've
Three
got
C-
sometimes
three two, C2.
sometimes when you have uncommon histologies, you can never do randomized trials. But we have a lot of evidence that tumors arising from different organs that share histology respond to the same drugs. Example, testicular germ cell cancers are very common and are very responsive to bleomycin, etoposide, cisplatin. Germ cell tumors of the ovary are not very common, but we've extrapolated using the phase 3 experience from testicular cancers, and we treat germ cell cancers of the ovary with the same drugs. And that's just based on phase 2 data because there's not a lot of germ cell tumors of the ovary. Small cell cancer of the lung, it's a little more prevalent than small cell cancer of the cervix. It responds to etoposide plus cisplatin. We've extrapolated that data, and we treat patients with small cell or neuroendocrine tumors of the cervix with cisplatin and etoposide, and we have excellent results. Another example is papillary serous carcinoma of the ovary. Carboplatin plus paclitaxel will put most advanced patients into remission 75% of the time, and so we extrapolate and use it for this disease as well.
So any role of radiation?
No.
No radiation. And suppose you find, we have a couple of cases where you find MMMT, not uterine papillary serous carcinoma, in an endometrial polyp. No, not everything else negative, just a 4 centimeter polyp, and it turns out to be malignant mixed Mullerian tumor with minimal myometrial infiltration, node negative. What is your practice in this case?
Surprisingly, carcinosarcoma, which is what mixed Mullerian malignant tumor is, the GOG has been able to study this in phase 3 randomized trials, and ifosfamide plus paclitaxel with Mesna in a phase 3 randomized trial improved overall survival, PFS, and response rate in completely resected carcinosarcoma. So stage 1 through 4, if you can get all the disease out.
No, if it is stage 1A, 4 centimeter.
Even 1A, completely resected.
Would you give any adjuvant treatment?
Yeah, yes. You got to listen to what I'm saying. Completely resected.
No, 1A. I mean, it was just a polyp.
Any stage, stage 1 through 4. So stage 1 through 4, carcinosarcoma, completely resected, ifosfamide plus paclitaxel with mesna to protect the bladder.
Okay, this is the last case. Quickly, this is a 45-year-old lady had presented with postmenopausal bleeding. Biopsy was well differentiated endometrioid adenocarcinoma, but this case actually what we discussed role of imaging. She also had an adnexal mass. So this is a ovarian mass, left ovarian mass here. So she has a big adnexal mass. How will you manage this case? Manas?
We'll need to find out whether it's two different primaries or it's a synchronous.
Very difficult.
Very difficult.
Intraoperative, unless of course histologies are grossly different, pathologists generally are not able to tell.
So it's very difficult. That's what.
And how will treatment differ? Suppose these are same or
surgery
different.
is complete staging, the debulking, everything.
Okay.
The first line would be surgery.
Okay.
And then
What will be the what surgery will you do in this case?
THBSO, adenexectomy, debulking anything in the peritoneum, just like the ovarian surgery, everything, pelvic nodes, para-aortic nodes, omentectomy, whatever is there. So the surgery has to be as per ovarian, and that would cover for the endometrium.
Okay, the final histology is moderately differentiated adenocarcinoma of the ovary, endometrioid type, and moderately differentiated endometrioid adenocarcinoma of the endometrium with superficial myometrial infiltration. Now what?
We would give the chemotherapy as per the ovary,
Okay.
because it's similar histology, and we would debate if brachytherapy is required for the endometrial part. But since it's away, I think only chemotherapy should do.
I would be very concerned that this was a metastasis from her endometrium.
But endometrium was actually very small lesion, superficially invasive. So
It doesn't matter about the invasion because it can go through the tubes.
okay, so suppose let's consider it as metastasis from the endometrium. How will how treatment will differ?
So she becomes a stage 3A endometrial cancer and should get chemotherapy.
Do you really think this is metastatic or it's contiguous? So you don't know?
They don't know.
This kind of a tumor, in your experience?
I don't know.
Actually, it's very difficult.
Very difficult to say it's metastatic.
I mean, I think it went through the tube.
So my question is, if it's metastatic versus synchronous, is the treatment any different?
It is. So
Yeah. So
if it's an endometrial, if it's a stage 1C non-serous carcinoma of the ovary, phase 3 randomized trial, GOG 157 indicates that 3 cycles is just as good as 6 cycles of chemotherapy. Subset analysis suggests that for the serous cancers, 6 cycles is probably better. So if you believe this is a FIGO 1A grade 1 endometrial cancer with a synchronous 1C endometrioid.
okay, let's make it 1A endometrioid ovary, not 1C.
So a 1A
1A grade 2 ovary.
Okay.
1A grade 2 endometrium, small endometrial lesion.
And it's a synchronous primary on the ovary?
I don't know.
So that's-
Pathologists are not able to tell whether it's synchronous or metastatic,
Right.
same histologies.
So you counsel the patient and say that if you've got a 1A to B, grade 1 to 2, non-clear cell cancer of the ovary, 3 cycles of chemotherapy is fine. But if you've got a metastasis from your endometrium to your ovary and you're really a stage 3, you should probably get 6 cycles of chemotherapy. And if you can't tell, probably it's better to err on the side of giving 6 cycles. But it's important that we understand the evidence and what the studies are so that when we counsel the patients, we know what we're talking about.
Right.
And
So don't you think, any role of radiation in this situation when disease is limited to the pelvis?
No.
And it's a
It doesn't improve
serious
survival.
histology for ovary.
It doesn't improve survival.
And it's endometrioid type. Of course, current evidence is for clear cell carcinoma of ovary, which is, classically chemo resistant. Now, recent studies have shown that they are radiation sensitive tumor. In fact, last year, ASCO.
Yeah, so if you want to do something for her, give her, talk to, in India, there's amazing pharmaceutical companies that are making some of the most amazing drugs that you'll see. I had a meeting with Sun Pharmaceuticals in Mumbai a few days ago. You can treat her with an mTOR inhibitor. The mTOR PI3K AKT pathway is very active in endometrioid cancers, and there's a lot of phase 2 data that suggests that mTOR inhibitors can help control occult residual disease. So if you wanted, we got to get away from thinking about radiation in endometrial cancer. It's really an old, outdated modality. It doesn't improve survival. We're all oncologists here. We're here to make our patients live longer. Now, to your point, if you've got a non-compliant patient, that's a completely different story. And in that case, I would agree, if you want to give vaginal cup brachytherapy, that's the thing to do. Vaginal cup recurrences are easily salvaged with radiotherapy, but the patient has to be compliant and present to you before the vaginal cup recurrence gets out of control. So if to your point, I completely agree. If you've got a patient with high-risk early-stage cancers, not advanced stage, early-stage endometrial cancer, and you're concerned about her compliance and other factors that I may not be familiar with due to the healthcare system in India, but I do take care of a lot of uninsured patients in the United States as well. But I think then vaginal cup brachytherapy can be very helpful. Yeah, and I think that's very, because we're doctors, so we're artists, medicine's an art, so we have to tailor things based on the clinical situation. So I've seen, so the NCCN guidelines suggest for cervix, endometrium, ovary, every 3 months.
What he's asking, the actual follow-up, not the protocol.
So in that case, if you've got an early stage patient with high risk factors, I think vaginal cup brachytherapy is very important. Very important. Yeah, if the follow-up is poor, then it's the problem. Our patients tend not to, in terms of moving the field forward, in endometrial cancer, we have to get away from radiotherapy. Cervical cancer, radiotherapy is phenomenal. Most cervical cancers are squamous, locally advanced disease. You can cure the patient with chemoradiation and brachytherapy.
So you were talking regarding mTOR inhibitors. Any data regarding the mTOR inhibitors versus the cytotoxic chemotherapy in the adjuvant setting?
Yeah. So targeted therapy, and we're going to talk about targeted therapy tonight when I give a lecture later. Targeted therapy usually has to be given in conjunction with chemotherapy because targeted therapy stops a process that's essential to cell growth and metastasis, but it doesn't kill the cell. So we still need to use chemotherapy with it.
Right. So I think the message here is conventional is paclitaxel, but it may not work in all cases, and one has to explore other options. And what is new actually is the role of radiation in clear cell carcinoma of the ovary, but that's for another panel, another day. With this, I think we lived up to our organizers' expectation, and we all will get food. So thank you very much for being here, and have a nice lunch.
Thank you, Dr. Amita and the panelists.